That is accommodated by these ladies who are walking around with cute little baskets, and they have index cards and golf pens in them. So if there's a question you would like to ask, just wave your hand. They'll make sure you get the materials you need. They'll collect them. The questions go over here to screen them to make sure it's not duplicating another question or that it's not appropriate for this forum. We know who you are. Everyone see them? Okay. We don't take a scheduled break, so if you need to use the facilities, go back out and go to my left here, your right, anyway, they're over here at the other end of the meeting room area up there. Okay, we are committed to providing these forms to you at no charge. So if you see the businesses that were up here as you came in, those are our sponsors, and we thank them all very much for their generosity in allowing us to do this without too much effort on anybody else's part. I'm not doing fundraisers. I am not. So you will see a box out there where you can submit donations if you've enjoyed this evening. We would appreciate it. All right, and I've gone over the questions. Exits, we have one exit here, and the other exit is the doors that you came through when you arrived. So the topic of our forum tonight is called Single Payer or Medicare, a Single Payer Medicare for All. History, why, and how. We've tried to get you as balanced a presentation as we always try to do, and I think we've accomplished that, and I hope you're going to enjoy this evening very much. I would now like to introduce our moderator for this evening. It's Rota Rosaschi, and I've known Rota for quite some time, and she is the Executive Director of the Nevada Public Health Foundation. She's held that role for 16 years, and prior to the foundation, Ms. Rosaschi worked for the State of Nevada Division of Welfare and Supportive Services for most of the 30 years in a variety of roles. And I'm not going to read the rest of that to you because you all have we're not going to read these to you. That's why we give them to you ahead of time. But I will say about Rota, one of her duties was to keep everybody on task. You know the latest fad right now is when we tackle an issue, we go, we need to have this conversation. We need to start the conversation. Rhoda's like, no we don't. No we don't. A little less talk and a lot more action. And that's what Rota does, and I've really appreciated that about her for many, many years because she does get things done. So without further ado, I would like you to welcome Rota.
Thank you, Kathy. Good evening, everyone. Glad to have you all here this cold winter night. You braved the snow and the cold weather to be here. As you see, we have 4 presenters that are going to be speaking tonight. I'm just going to do a brief introduction as we bring them up so they can speak. We're going to have Charles Duarte come up. He's going to be our first speaker. Mr. Duarte is the Chief Executive Officer of Community Health Alliance, a nonprofit federally qualified health center with 6 fixed health care sites in Washoe County, as well as a mobile dental program and a women's, infants, and children's supplemental nutrition program, and he runs that in the Washoe County area. He is also the former Nevada Medicaid administrator, and he served in that capacity for 12 years. It is actually one of the longest serving administrators of Medicaid in the history of the state of Nevada, actually. And I was talked into being a member of the Medicaid Advisory Council by somebody, and I'm still that member all these years later. He's long gone, but I'm still there. So, Chuck, nice to see you. Thanks for coming.
Thank you.
What we're going to do is we're going to have everybody speak for 20 minutes. I'm going to stand up there when it's about 20 minutes. I'll give them a sign when it's about 5 minutes, so you know, yes, quick. So that's a good idea. I'll just go ahead and leave here, let him speak, and then I'll introduce the other 3 as it's their time.
Thanks a lot, Rhoda. Good evening, everybody. So again, my name is Chuck Duarte. Besides serving as the Medicaid administrator, I've got about 20 years in all in healthcare financing experience. So hopefully I can bring some new information to you all. And, as a part of my job as a healthcare administrator, I often get asked to do presentations, and about 2 weeks ago I got asked to do a speech. And so the usual thing, us administrator types do, we do a PowerPoint presentation. So I did this really cool PowerPoint presentation. I took it to the event, and I gave the presentation, and everybody was just surprised as heck, particularly the bride and groom. All right, got you all warmed up here. And again, forgive me for wearing my coat, but I see everybody else is wearing coats, so I'm not feeling too bad. So tonight, what we're going to cover is Medicare for All, and what I want to do is talk a little bit about the history of healthcare financing in the United States and elsewhere. And I think that's important because the question is, how did we get here? And the United States is rather unique in regards to how it pays for healthcare and how it delivers healthcare compared to other industrialized nations across the world. And so it's important to understand the history of it. And one of the things I like doing is I like talking about history. And so I often do these presentations. Let me see, I think I've lost my page already. And I give these talks to med students and public health students. And one of the things that I like to do is to take us way back in time, back to the 1800s. And, talk about how here in the United States, we were looking at healthcare and how it was delivered. And it started off with something called sickness insurance. And the first insurance company to offer sickness care was the Massachusetts Health Insurance Company of Boston in 1847. And it didn't grow much beyond that after 1847. But what really started to change things was the changes that were going on socially and politically in Europe. And so in 1883, what you saw was an increasing growth in the Communist Party and growth in socialist movements across the European continent. And Otto von Bismarck, who was the head of the German Republic at the time, he saw this movement growing, and he felt that he needed to do something in order to stave off a potential revolution in his country and a takeover. And so one of the earliest things that he did was he passed national health insurance, and it was really one of the first nations to pass nationalized health insurance. And so that was in 1883. And then fast forward a little bit to the 1900s, and back to the United States, Baylor University Hospital had an agreement with school teachers. And what they did was they offered hospital insurance. So they didn't cover everything, but they covered hospital care. And that eventually became Blue Cross of the United States. In the 30s, President Roosevelt planned and established a universal health coverage, and he was going to try to pass it along with Social Security. However, there were some folks out there who didn't like what he was doing, particularly the American Medical Association, and they threatened to kill Social Security if he was going to pass legislation enacting universal health coverage. And so in order to maintain what he thought was a more important program at the time, Social Security, he dropped universal health coverage from the bill, and he did get past the Social Security program. Some changes really started to happen in the 40s and 50s, and in the 40s, of course, we had the Second World War. And what happened during that time were wage and price freezes. So across the United States, companies were not able to increase wages. And so one of the things that they sought to do was to offer employee benefits. So it was a way to attract employees in a very tight labor market, because all the boys were overseas, but in a very tight labor market to attract employees. And so they offered things like health benefits. And there was a rather arcane provision in tax law that was enacted that allowed employers to offer health benefits tax-free or tax-exempt. And so for these employers, it became an affordable way to increase overall compensation for employees, attract a workforce, and to maintain a workforce while they were experiencing wage and price freezes. And so along that time, when we had these wage and price freezes, right afterwards in the late 40s and the early 50s, we saw the expansion of Blue Cross Blue Shield, and they really grew as a result of unionization across the nation. And they became a very important benefit for union members across the nation. So much so that 57% of all employees had hospital insurance through some form of unionized benefit. And of course, everybody knows it happened in 1965. Besides the Vietnam War, it was the war on poverty. And President Johnson signed Medicare and Medicaid programs into law. And do you folks, any of you folks know, you history buffs, who were the first and second Medicare card holders in the United States? Anybody?
Harry Investor.
Oh! Where are you out there? Boy, he gets a bottle of wine. I think that's terrific. Yeah, Harry and Bess, they were the first and second Medicare beneficiaries. And again, Medicare was opposed by the AMA at that time. I think they've kind of changed their tune, but you know, they were opposed for a variety of reasons. And then fast forward again to the 1980s to 2000, and we had passage of a number of different acts, all sort of incrementally adding to health coverage in the United States. You know, none of these were like large expansions of any program, any single program, but they added to existing programs. So the HMO Act, Health Maintenance Organization Act, COBRA, HIPAA, Family Medical Leave Act, those are all additional pieces of legislation that were passed to expand and strengthen health coverage. So again, in the 2000s, we had a number of other incremental changes and additions that were contributed to the expansion of healthcare coverage in the United States. 2000, it was the Children's Health Insurance Program, an important program for low-income kids. In 2003, the Bush administration passed the Medicare Prescription Drug Improvement and Modernization Act, which became Medicare Part D. How many of you folks have Medicare Part D coverage? Good. I'm going to talk about how that's actually financed in just a bit too. 2006, Massachusetts mandates that residents must have insurance by 2009, establishing the first health insurance exchange and the first statewide mandate for health coverage. 2010, the Affordable Care Act, or Obamacare, its real name is the Patient Protection and Affordable Care Act, or PPACA. That was signed into law in 2010, making it illegal for insurance companies to rescind insurance on sick beneficiaries, and also made it mandatory that consumers have insurance. And so in 2014, that became a mandatory provision of health insurance in the United States. And so in 2014, what we really saw was the expansion of the health insurance exchanges across the United States, the healthcare.gov exchange at the national level, and then equally important was then 33 states currently, I think it's going up to 37 states, the expansion of the Medicaid program to cover low-income individuals who otherwise weren't eligible for Medicaid. And so that's kind of where we are today. We've kind of run up the history to the point where we're here, and we still have issues with healthcare costs particularly, so the battle is going to continue. But one of the things that's important for us to understand as we go forward, and I think Dr. Lyons may touch on some of this as well, is how do we compare to other nations? So there's an organization that I like to quote. It's OECD, it's French, Organisation Économique something or other. It's the Organization of Economic Collaborating or Cooperating Developing Countries, OECD. And they produce great data across the world. And so one of the things that they look at is healthcare and healthcare coverage. And so, of course, one of the things that we always talk about is, you know, the cost of healthcare. So how do we compare relative to other nations when we look at the cost of healthcare? And if you look to the far left, I don't know, I'm sure you can't read all the countries. So on the far left, the most expensive on a per capita basis is the United States. And we spend about $10,000 US per person per year in the US. That's followed by Switzerland at $8,000 or a little less than $8,000, and then Luxembourg, Norway, Germany, and you can see all the way down the line the countries that spend a heck of a lot less on healthcare than we do. We are and have been for the last decade the country that spends the most per capita on healthcare. So, what does that get us? You know, for all that money, we should have the best healthcare system in the United States. Oh, by the way, we also have the highest out-of-pocket costs. I forgot to mention that. So how do we compare? This is life expectancy after birth, and so looking at how long people live across the OECD countries, and you can see that we are the 28th lowest amongst industrialized countries or OECD countries. So that those dollars really aren't doing a heck of a lot when it comes to things like life expectancy. Well, what about infant mortality? That's a really important measure of how our healthcare dollars are getting spent and what we do to prevent preterm birth and infant mortality. We're the 33rd highest in terms of infant mortality. That's not a good thing, okay? Having low life expectancy and high infant mortality and the highest cost of any nation per capita means that we're not really getting a lot of value out of the dollars we spend. Kids are dying, people are living shorter lives, and it's not all because we have unhealthy lifestyles or we have mental health problems worse than any other country. Yes, we have some of that, but a lot of these other countries also experience some significant problems from an epidemiologic perspective. So it's really how we spend our dollars and where we put the emphasis for our spending that's the problem. So one of the things we're going to talk about tonight, and I think Dr. Lyons will probably touch on some of this, is what about other countries? What do they do? And so this is just a really brief summary. And so, one of the questions a lot of people ask are which countries have universal health care? And it's just about every industrialized country in the world has some form of universal health care. You can see the list there. Is Canada's health care free? That's another question that's commonly asked. Canadian healthcare basically works like Medicare in the United States, but for everyone, Medicare is free in Canada, and it covers almost everything except for some items like prescription drugs, glasses, and dental care, and so most people have supplemental insurance to cover those costs, or those kind of extra items. And there is actually private health insurance in most industrialized countries. So, when you talk about socialized medicine, there's a definition that a lot of people use, and it's been, I think, expanded a bit here in the United States, depending on your point of view. But normally, when you talk about socialized medicine across the globe, what you're really talking about is where the government pays for two things. It not only pays for insurance, but it provides the services. So things like government-owned hospitals, government-employed physicians, government-run healthcare. That's what really socialized medicine was meant to mean. In the United Kingdom, for example, there is some form of socialized medicine using this definition. Their hospital systems, a lot of their physicians are employed by the government, and they love their healthcare. I don't know how many of you remember the Olympics and the big show that went on before the Olympics started, and it was the British, the folks in the United Kingdom were celebrating their healthcare system as a part of the Olympics. I mean, that was their highlight. They're so proud of their healthcare system. But it is a socialized system. However, the definition of socialized medicine has been broadened, like I said, and it's sometimes used to define systems that are funded by the government, although healthcare is provided by private business. So if you think about the Medicare program, it's funded by the government, although part of it is funded by the premium, the dollars that you put into it, and I'll talk a little bit about that. But it's a government program. Its services are provided by the private sector. So depending on your definition, it's socialized medicine. The VA, Veterans Administration, government provided, government run, that's socialized medicine. Medicaid, government funded, privately provided services, again, depending on your definition, socialized medicine. So it's not unusual for countries to have this form of health care, and most modern democracies have universal health care, unlike the United States, but the services are provided by the private sector. So again, I just want to make sure people understand that, we are somewhat unique because the majority of our health coverage is provided either by the government or by employers. And as we see, the cost of that is extremely expensive. I'm going to cut this a little short, but one of the things I think it's really important to understand, because a lot of people really don't understand this, is what is Medicare, including this crowd. You'd be surprised how many folks don't really understand what Medicare is, what it does, and how it's paid for. So Medicare is for those 65 and older, but it's also for people with disabilities. It's targeted at people with end-stage renal disease as well, regardless of age. And then like Social Security, it's an entitlement program. So entitlement is a bad word to some people, and it's important to understand what it is. An entitlement program is actually a property right. So in federal law, when you have an entitlement to something, you have a property right, in this case for Medicare, because of your age, or because you have end-stage renal disease or a disability, you have a property right to that benefit. So that's what an entitlement is. It's not a bad thing because it assures that people who are 65 years of age or have a disability can get Medicare. Entitlement has nothing to do with being deserving. So there are 4 parts to Medicare. You're all familiar with this, right? There's actually 5, or excuse me, 4. A is hospital. B is medical insurance for things like physician services. C is Medicare Advantage programs, Medicare Advantage plans. Part D, prescription drug coverage. How's it paid for? Well, you folks do pay for Medicare, but only for Part A completely, or almost completely. So Part A is hospital benefits. So as you work your 25 qualifying quarters throughout your life to get Medicare. You're actually putting most of that into just the hospital system. Part B, which is physician services, diagnostic care, and those kinds of things, that's government subsidized. So that's paid for the most part, 73% of it, with taxes. And then Part D, prescription drug coverage, is also paid with general tax revenue, and so it is subsidized. So really the only one that we pay for as we're working stiffs is, for the most part, is hospital care. The rest of Medicare is paid for by everybody else. So we are beneficiaries of each other's work effort, which is not a bad thing, because that's part of being part of a nation, a collective. I was going to talk about Medicaid, but I'm going to skip this for now, because we're here to talk about Medicare for all. And so with that, I will end my presentation. This presentation will actually be available to you folks up in front as you leave, and so it's got my contact information there. If you have any questions, I guess we'll be answering questions at the end of the panel presentation. So thanks for your indulgence and thanks for your attention.
And Ms. Korbulic joined the Silver State Health Insurance Exchange as the Chief Operations Officer in August of 2015. And prior to that, she was with Aging and Disability Services. And as Mr. Duarte mentioned the exchange, so it's now our turn to learn about what the exchange has to offer. Ms. Korbulic?
I would be remiss if I did not correct you. It's Korbulic, sorry, I have to say. Yeah, thanks. I'm actually the Executive Director of the Silver State Health Insurance Exchange. I've had that joyful position for about 2.5 years now, for almost 3 years, and it has not been boring at all. It's a wild ride pretty much every day, and starting in January of 2017, it got a little bit more intense almost every minute of those days. So I thought I would start just because it's important for me to make sure that everybody understands the role of the Silver State Health Insurance Exchange. So if you'll indulge me just for a moment, I would like to just fill you in. The Silver State Health Insurance Exchange is the state agency that runs the Nevada Health Link, which you may see our ads or hear our ads for Nevada Health Link during our open enrollment period. We're the same thing, basically. Nevada Health Link is the forward-facing operation that is the exchange. What we do is we facilitate the sale of Affordable Care Act compliant plans. So for consumers who are not eligible for Medicaid or not eligible for Medicare and who don't have an option of employer-sponsored or their employer doesn't give them insurance, then we're that connection for them. We can connect them to affordable, comprehensive health benefits. In 2010, our governor decided, Brian Sandoval decided that he was going to expand Medicaid and set up our own state-based exchange. Not every state has its own state-based exchange. There are, I think, 20 of us total. And the Silver State Health Insurance Exchange, you may remember back in 2014, had a bit of a rough go. And so we currently are operating in a kind of hybrid model where we use healthcare.gov to do our eligibility enrollment. But the exchange in Nevada, Nevada HealthLink, we do all of our advertising, we do all of the stakeholder development, we work with plan certification, we do all sorts of boring, long lists of things. But we're still a really critical component. And just FYI, we are transitioning back to a full state-based exchange. We're getting rid of healthcare.gov and going with our own system in next plan year. So November 1st of this year, we'll be going live with our own system all the way back to state-based exchange again. For those of you who are interested, there are 83,449 consumers on the exchange this year. We did see a decrease in our enrollment of about 8%, unfortunately. And I can talk a little bit about why that is, and that has a lot to do with federal instability and kind of lack of support at a federal level. Of those 83,449 consumers, 84% of them are actually eligible for subsidies. So they fall within an income range of, this is technical, 138% to 400% of the federal poverty level. Being in between those two, in that range, qualifies them for premium subsidy assistance. So they get an algorithm based on their income, dependent on their income, that helps them afford their insurance. For people who are over 400% of the federal poverty level, who are still needing individual market plans, there is no subsidy. And that's an area I'd like to talk a little bit more about. So people think of the Affordable Care Act and they immediately think of the exchange. And that's not what all the Affordable Care Act is. Although that's been a lot of the policy focus at a federal level has been on exchanges, Medicaid expansion is probably the most significant portion of the Affordable Care Act. In 2012, our uninsured rate in Nevada, 2011, 2012, was about 23%. Now that we've expanded Medicaid and we have our own state-based exchange, our uninsured rate is, depending on who you listen to, about 10%. Of that 10%, about 7% of that population, or 7%, is actually in an immigration status that doesn't allow for them to be eligible for Medicaid or for ACA or the Affordable Care Act subsidies on the exchange. So if you kind of do the math there, we're looking at about 3 to 4% of Nevadans who are uninsured, which is a significant achievement if you think about 2014 and we had 23% of our population uninsured. The number of newly eligible people on the Medicaid program is currently at about 219,000 people who are on Medicaid who were not eligible for Medicaid prior to the Affordable Care Act. And like I said earlier, on the exchange, we have about 83,000. One of the best parts of the deal of expanding Medicaid is that you bring a significant amount of money to your state from federal dollars. And in the beginning, when a state expands Medicaid, all of the match, the federal match, is paid for. 100% is paid for. Now that tapers down, and we're seeing at the legislative across the street at session, we're starting to see that tapering and the state responsibility start to increase. But it will bottom out at 90%. So forever, as long as the feds hold to their word, the 90% match will go on and on and on. So it's still a really good deal for states. And in fact, it brings, in Nevada, we have $1.3 billion in 2017 from federal dollars that are coming to our state. It's a pretty significant amount of money. Another interesting thing I think has happened because of the Affordable Care Act in Nevada is 16,000 jobs were created as a result of the Affordable Care Act. Whether that means it was a position that is direct care provider, a nurse, or a physician, or it's the administrative support for those positions, the Affordable Care Act has deeply impacted our economy in terms of job growth. let's talk a little bit about the good things about the Affordable Care Act, and I promise I'll talk about the challenges because I can be a little biased. I see the good things most of the time, but I also know very well where our pain points are. There's some things in the Affordable Care Act that I think maybe go unknown, and this is maybe not one. Guaranteed issue, otherwise known as pre-existing condition protections. Basically, what the Affordable Care Act does is say that you must, insurance company, offer insurance to anyone who applies regardless of their age, their geography, or their health status. You can no longer write them a different rate because they have COPD or whatever the case may be. That's huge. That's a dramatic change in what was going on in 2013. Community rating is another coupling part of what a guaranteed issue is. The community rating means that if my neighbor has a health condition and is the same age as me, the insurance company still has to offer them the exact same rate that they're offering me. Now that's what created some challenges originally when the Affordable Care Act rolled out. Because suddenly we have this huge pool of people who are newly eligible for insurance, and some of them are sick. And some of them were so sick that we didn't recognize the level of costs that we would incur, or insurance companies would incur as a result of those illnesses. So community rating and guaranteed issues are pretty much these foundational parts of the Affordable Care Act that really have offered so many consumer protections. The other thing that you probably know all about is that children up to the age of 26 are allowed to stay on their parents' insurance policy. And then the insurance that is offered through the exchange is required to have and cover 10 essential health benefits. And if you'll indulge me, I would like to read them. These are outpatient services, emergency services, hospitalization, maternity, newborn, mental health, substance abuse, or services, behavioral health treatment, prescription drug coverage, rehab and rehabilitative services, lab services, preventative and wellness services, and self-managed or chronic disease self-management, pediatric services that includes oral and vision. That's a huge expansion on what was previously offered in insurance or required to be offered in insurance. So before the Affordable Care Act, there was basically 3 in 5 people that didn't have maternity coverage. 1 in 3 people didn't have coverage for substance abuse treatment, and close to 1 in 5 didn't have coverage for mental health care. Think about the problems in Nevada right now in terms of where we're seeing kind of the most peak usage. We have a significant opioid issue, we have a mental health crisis, and if we were to not have insurance that required mental health coverage, I think we would see ourselves in a really dire place. Back in 2010 and 11, almost 1 in 10 people didn't have any coverage for their prescription drugs either. And what's the #1 cost right now for consumers out of pockets? Typically prescription drug coverage. So the 2 other things that the Affordable Care Act did that is wonderful. It eliminated lifetime caps. So people were no longer told that they were going to have an annual limit or a lifetime limit. So for instance, if you have a chronic disease or some kind of like COPD and you are going to incur $1 million worth of care. It used to be that an insurance company said, we will only pay $1 million and anything after for the rest of your life will be on you. But that's no longer allowed under the Affordable Care Act. So let's talk a little bit about challenges. Like I said and alluded to earlier, we have people who are over 400% of the federal poverty level, and let me give you a number about what 400% of the federal poverty level looks like. 400% is about $48,000 for an individual, or $98,000 for a family of 4. So anyone over that is not eligible for a subsidy. And so they're paying the full sticker price for health insurance. They're subject to extreme changes in volatility in rates. And these are the individuals that in 2018, this last year, when we saw rate increases on average of 38% on the exchange, had to pay that full price. People who are subsidized, when rates go up, so does their subsidy assistance. So people who are unsubsidized were paying and are paying full sticker price. And that's unaffordable, to the point where many people were unable to afford their insurance and had to go without. So One of the challenges is, why do we have such a steep cliff there? Is that necessary? And there are a lot of lawmakers in Washington, D.C. who have proposed bipartisan legislation that would essentially remove that cap. They would say, regardless of what your income is, that same algorithm of subsidy assistance applies to you no matter how much you're making. You're eligible for subsidy because we don't want you to pay more than, one of the bills says, 8.5% of your income toward health insurance. Right now, the maximum amount that people who are subsidized pay for health insurance is 9.6%. It is a lot, yeah. So the individual mandate was repealed, and maybe many of you are aware of that. That's a tax penalty associated with going without insurance. And that portion of the bill was actually, or of the Affordable Care Act, wasn't actually repealed. And I'm telling you this as a wonky policy person because it drives me crazy when people say it was repealed. It wasn't repealed. It was zeroed out. So no longer is there any tax associated with it. It's still a part of the legislation. It hasn't gone away. You just don't have to pay a penalty any longer. That was really a driving force for some people in getting insurance. So if you went without insurance, you had to pay a penalty. You were either going to pay this penalty and have no insurance, or you were going to pay for insurance that was relatively affordable, protect yourself and your family, and not pay a penalty. That was a driver for some people to get insurance. And so without it, I think that's why we've seen a slight decrease in our enrollment this year, because people are making a choice to go without insurance rather than covering themselves, and mainly because it's too expensive. So there's some ideas going around Washington, D.C. right now about what to do differently in terms of an individual mandate. Because if we're committed to universal or single payer or whatever we want to call this, if we're committed to making sure that everybody is getting access to insurance, then we really do need to come up with some kind of penalty for people who do not, to incentivize, reverse incentivize, I guess, them into the market. And that really looks like some people are proposing premium surcharges. So if you're on Medicare and you sign up late after your 65th birthday and past your timeline, you will incur a $6 penalty, whatever it is penalty. It's usually around $6 depending on when you entered into the market. But it's a $6 penalty that you pay monthly for the rest of your life on Medicare because you missed the timeline. So there are proposals that would suggest that we would essentially put a surcharge onto people who don't get coverage or they get late coverage. Not forever, but for at least a few years. Another thing that we see that's challenging with the Affordable Care Act is something called the family glitch, and I'm not going to bore you to tears about the very nuanced details of it, but it's an important problem. And I think there's some legislation that I've been asked to talk a little bit about that could possibly address that. The family glitch is basically, so I said earlier, 9.6% is the maximum amount that people are supposed to pay for their insurance. And basically, if somebody is getting insurance through their employer, and that insurance is 9.6% of their income, but then they have children, those children aren't counted. So they're having to pay for those children the full price, and it's not counted as part of being their benefit. So they're not eligible for subsidies on the exchange, and they're paying full price for all of these people. That family glitch has been known forever, and it hasn't really been addressed in federal policy, and I don't really have all that much hope that it will be. But I wanted to tell you a little bit about something that's been going on really in Nevada and kind of in 10 other states. There's a discussion that is sort of relative to Medicare buy-in option, and that's the Medicaid buy-in option. In Nevada in 2017 legislative session, Assemblyman Sprinkle passed a bill called the Medicaid buy-in, Medicare for all, or Medicaid for all. You might have heard of it as Sprinkle Care. And that bill was eventually vetoed by Governor Sandoval, and that was because the bill really kind of lacked a lot of detail. But there are some potential things that a Medicaid buy-in option could do. Essentially what the buy-in option would do is it leverages state Medicaid plans and networks and pricing and allows any individual or some individuals, depending on how you define it, to buy into that plan. This could offer a less expensive option, and it could also address that 7% of the population that we're talking about who is in an undocumented status or is not eligible for Medicaid or Medicare or ACA subsidies. And it could also have implications for the family glitch. So people who are finding that they can't afford their employer-sponsored coverage for their children could purchase a Medicaid plan. Now, there's some pros and cons, and I see I'm running out of time, which I'm happy to wrap it up here. But basically, I told you what it could impact. The problem is we don't have clarity on the costs. Who would be able to buy in? That's a very complicated question, because if you say for all, does that mean you and I, who are on Medicare, we could buy an option, or on my employer-sponsored, I could buy into Medicaid instead? That's a very complicated question that needs answering. The second is, who is going to provide it? Is it going to be a private option? Are we going to leverage the managed care organizations that operate Medicaid in our state? And then second, who's going to oversee and regulate it? Who's going to pay the claims? Is it going to be, are we setting up our own state self-insured insurance company? What are we exactly doing? These are policy questions that have real implications when you go to implement a policy that need definition before we can really implement something like that. So, happy to wrap it up and hand it off and answer questions later.
The Advantage plans that were supposed to save us so much money? No, not really. This is the standard traditional Medicare in the U.S. with an overhead of 2%. This is very similar to what you find in Canada at about 3%. This is your Medicare Advantage plans. They're good for you as individuals as long as you don't get sick. We'll go into that. But for taxpayers and for our healthcare system, these are just more bureaucracy and more wasted dollars. They've got 4.5% for profit, and they've got 9% for overhead. And these companies, they know how to get the money. And so when you audit them, you find out they're upcoding and things like that to the tune of about $3,300 per enrollee. Now, if you get sick on one of these Medicare Advantage plans, you may rapidly decide that you'd rather not be on one the following year. These are patients that have to require a short-term nursing home stay or a long-term nursing home stay who switch out of the plans the following year. The yellow are all the people switching out of the plan. They also know how to cherry pick in a variety of ways. They basically take care of the weller patients. If you're sick, you're not going to like the narrow networks, you're not going to like the formularies, you're going to have to go back to traditional Medicare to get adequately cared for. Now, this is VA hospitals, okay? We get lots of media about how bad they are. That's because you can actually access the data. You can't access these corporate boardrooms, okay? But they do great. Pneumonia, congestive heart failure, heart attack, and stroke. Lower death rate. The non-VA are the taller ones. The VA are the lower bars. And these are readmission rates. Okay, so now we're actually getting to the proposal.
We're running out of time.
Yeah, no. I talked to the other presenters, and they get 20, and I said 30. So anyway, the proposal by the Physicians for National Health Program is a single-payer improved Medicare for all. It's universal, covers all U.S. citizens. It's comprehensive. It covers all required medical care without copays and deductibles. This is very important, including medications and long-term care. The physician proposal includes long-term care, nursing home, and dental. That is not included under Medicare currently. It also is a single public payer with privately provided services, but there are no for-profit facilities, hospitals, nursing homes, etc., and there's no for-profit provider networks like HMOs or ACOs. There's public accountability, so it's not behind a boardroom door. And then there's public health planning, so that there's not duplication of services and excessive capacity. So you take all the funding that we're spending currently and in the all myriad different ways that we're doing that, like all our Medicaid programs, 50 different Medicaid programs for 50 different states, and all the administration and jobs like Heather's. And possibly Chuck's. And you put that into the fund, you put the Medicare into the fund, you put the employee subsidies into the fund, etc. And yes, there are some additional taxes. You got those handouts on those taxes. We'll talk a little bit more about that. So when you cut the administrative waste that goes on in the United States from the insurance companies, which take it right off the top, 15 to 19%. So that's $150 to $200 off the top of your $1,000. By the way, that's how much it costs for Carson City to insure their employees. It's $1,000 a month. It's an average of $12,000 a year to insure a Carson City employee. So you take that right off the top and you get rid of these Medicare Advantage plans. You decrease the administrative overhead that's happening to hospitals and to doctors from the 25% that we experience in the U.S. to the 12% they experience in Canada, and that's a boot-goot lot of bucks, okay? That is this big circle here, which is $476 billion, which in and of itself is enough to cover the expansion and the improved services. Then you start negotiating as the VA and the military do for healthcare costs, and you reduce those by 50%. You've got another $116 billion. Now, the cut point when you look at the additional taxes is $250,000. If you have a household income greater than $250,000, then you might not like this. But just remember, even those, unless you are independently wealthy at greater than a lot, you are still at risk for medical bankruptcy. Okay? So 95% of Americans have a household income less than $250,000, and so they will all be better because you won't be paying the copays, the deductibles, the premiums, etc., the out-of-pocket expense. Now, this is what Canada did when they enacted this program back in the mid-1960s and fully enacted in 1970. They had been tracking us for the amount of money they were spending gross domestic product, okay? But when they enacted the program fully, you can see that their rate of increase is significantly lower than our own, and half, essentially, of what we're spending. Michelle, maybe you can mention the arms race when it comes to cardiac care, etc. I won't go into it. Now, we've tried lots and lots of different things. HMOs, managed care, pay for performance, all these different things. None of them have been proven to work. This does work. We saw the curve on Canada. We see the curves in the other nations, okay? Negotiated fees, global budgeting for your facilities like hospitals and nursing homes, which Michelle will go into a little bit more. And the capital planning, where you have regional planning, like are you going to build a new hospital or not? Okay? Do you need a new hospital or not? So bending that cost curve over a period of a decade could save us $1.8 trillion, which is enough to make it a sustainable program. Now, don't be fooled by the lookalikes. 60% of American taxpayers favor single-payer Medicare for all, and so do 60% of doctors. That's got insurance companies running scared, and so they came up with this plan called Medicare Extra for All, okay? They're willing to throw the drug companies under the bus, but it doesn't change anything for them, okay? And throwing the drug companies under the bus, as you saw, is only $116 billion, not enough to make a big difference. The Medicare Advantage for all would be wonderful for the insurance companies because, remember, they get your Medicare benefit plus another 12 to 15% from the taxpayer, so they would absolutely love that. And the public buy-in doesn't really change anything, doesn't get rid of the bureaucracy, doesn't create a system of healthcare. So next steps. Read the handouts, look at the Physicians for National Health Program website, share the information with your family and friends, advise your senators that you want single-payer, improved Medicare for all, and your congressional representatives, and you want the VA adequately funded, not privatized. I have 25 handouts, more about the VA privatization that's going on. That's really detrimental to us as taxpayers as well as to our vets, if you want that. And then tell your governor to push for a United States solution. When you travel, you don't want to be out of network when you go to California, or you go to Oregon, or you go to Utah. Okay? And emergencies do happen. So we need a national response to this.
Well, that's all the time we have for tonight.
All right, good deal.
Our last and final speaker is Michelle Joy. Ms. Joy has 20 years of healthcare executive leadership experience. She joined Carson Tahoe Health in January of 2015. Prior to coming to Carson Tahoe, she has experience with healthcare and leadership in Iowa, Susanville, California, and Colorado. So, Ms. Joy.
All right, good evening. Thank you for allowing me to speak tonight. And that's a tough act to follow, Colleen, but she covered a tremendous amount of information and was spot on with the complexity of the U.S. healthcare system, the cost burden that is out there. What I hope to do tonight is be able to provide you with maybe some pros and cons from the hospital perspective related to single payer. But I wanted to share some information based on what Colleen was saying. And so Carson Tahoe is a not-for-profit hospital. It doesn't mean that we don't make a profit. We do make a profit. The difference is that the profit that we make gets reinvested into the community. It's reinvested in services that we provide to the community. It's reinvested in our employees, as well as into the capital and improvements that go into the hospital. The difference with the for-profit sector is that those profits go into the shareholders' hands, the stockholders' hands, and the executives within those for-profit companies. When you look at the U.S., the number of hospitals, if we go back to 1981, there were roughly 6,900 hospitals in the U.S. In 2018, that number had dropped to just over 5,500, so 1,400 less hospitals. A number of reasons for that: improvements in technology, moving things from the inpatient side to the outpatient side, folks having to spend less time in the hospital. Before, you would spend several days following a surgery, following a delivery. Now you're in and out within a day or two. I'm not saying whether that's good or bad, but that's the reality of the situation. When we look at that total of 5,500 hospitals, 25% of those are for-profit. So going back to Colleen's comments regarding for-profit hospitals. A couple of statistics that I wanted to share for Carson Tahoe specifically is when we talk about the various payers that are out there, Carson Tahoe, our net revenue last year, and healthcare financing is complicated to understand because we charge a price. It's not actually what we get paid, but our net revenue, what we actually got paid from all sources of funding, was $300 million. 55% of that came from Medicare, 3% was self-pay, uninsured, 15% was Medicaid, and the rest, roughly 27%, was private insurance. When we look at that net revenue, you figure the hospital tries to achieve a 4% operating revenue. So what that means is out of that $300 million that we got paid from all of those payer sources, at the end of the year, we want to be able to have about $12 million in profit. That's a 4% operating margin. Not a lot of profit coming out of the organization to be reinvested. So when we look at that $288 million in expenses, roughly 54% of our revenue goes to labor. So for Carson City, Northern Nevada, that is $162 million entering the economy from a labor perspective. Colleen touched on the drug costs. So 10% of that revenue is towards pharmaceuticals. So roughly $30 million is our spend annually for drugs. And then the other another 30% is spent on all of the supplies that we use to take care of the patients. And that comes to about $90 million a year. So those are the numbers that we're talking about from a specific local community hospital. Sorry, gotta point it that way. So some of the terminology, you've heard this. I put this slide in here just to kind of lay the baseline of where I was coming from on the subsequent slides. So we've talked about terminology around Medicare for all, universal health care. It's financed by taxes, and it covers the costs of essential health care. Very similar to the Canadian system, publicly funded, mostly free at the point of service, everyone receiving the same level of care. Typically, elective procedures are not covered, and the family physician makes the referral to see the specialist, which isn't any different than we have currently with our managed care and HMO plans that are out there, where you have the gatekeeper model, and the primary care needs to make the referral to the specialist. Medicare is a single payer system for those over the age of 65. Chuck talked about it in detail, younger people with disabilities, end-stage renal disease. And you know, when I put this presentation together, I was not looking at the VA as a single payer because it's owned, operated, and financed by the government, as Colleen talked about. From a single payer perspective, there would still be private hospitals, not for-profit hospitals. So in 2017, the New England Journal of Medicine did a survey of healthcare executives, clinical leaders, and clinicians regarding what do you think would be the best outcome for future payment reform. A lot of agreement out there that there needs to be payment reform from what our current system is. And almost 50% of those surveyed identified a single payer healthcare system, with 55% of the clinicians supporting it, and I fall into the bucket of the 39% of healthcare executives. So not a lot of support from the healthcare executive side of the world, and there's probably reasons for that. So when we look at potential hospital impact, one of the positives of moving to a single payer system is the preventative services and access to ideally primary care. Everyone has health coverage. We've seen it with the Medicaid expansion that when individuals have access to health care, they will utilize services proactively early on when they become sick versus waiting and waiting and waiting because they don't and can't afford to access health care. So overall health ends up being improved. Ideally, there's less need for high-cost emergency room visits and hospital services. From a one-payer perspective, Colleen hit this really well from the administrative burden, the number of programs that are out there that have to be managed, costs get reduced, there's less need for ongoing contract negotiations with every single private insurance payer that's out there. Hospital billing costs absolutely become reduced, and there is a loss of jobs that goes with that administrative burden that's there. One of the things that the American Hospital Association noted is that on average, Medicare rates, what hospitals are currently reimbursed for the care that they provide, only covers roughly 88% of the cost of taking care of a Medicare patient, while payments from commercial insurance cover almost 144% of hospital costs. So from a hospital financing perspective, it's the cost shift that occurs. And when you think about it from this perspective, the public is already subsidizing Medicare, Medicaid, and uninsured that's coming into the hospital. And it's being subsidized by the public through the insurance premiums and copays that everyone's paying when they come into the hospital. So there is the concern that taxes are going to be raised under a single payer system, but there's already subsidies taking place. It just goes through the form of the private insurance. So I don't know a lot about global budgeting, but that is the funding mechanism under the single payer system as well as the Canadian system. The way that controls costs end up being controlled under global budgeting is that it caps the amount that is spent on healthcare. Again,
You're on the sync with your slides. Yeah.
Oh, sorry. There we go. Again? Okay. All right, sorry. So from controlling the cost by capping the amount that is spent and available for hospital services, healthcare services, there is some that say that once that money is gone, you could potentially end up waiting for services. It could lead to a reduction of services offered in the community. The other side of that is really from a regional planning perspective. As Colleen touched on, you're looking at things from a much broader perspective and how many MRIs are really needed to take care of the community being served, how many CT scans are needed, what is the appropriate services to be provided in each location. So it could be a reduction in services in some areas, it could be a leveling and reducing excess capacity that is currently in the system that's raising some of the costs that are out there. Depending on what happens, it could lead to less employees, some access to care could be diminished. There's question on investment in new technology as you limit access to capital and what capital is available. Potentially less innovation. It's debatable on whether or not quality of care could suffer. So those are arguments that you're going to hear against single payer that are out there. Potentially more of a physician shortage as more people have access to coverage and are seeking care. It's going to limit the availability to be seen by physicians. And so I share a few slides. This one is, again, talking about the Canadian system. It's a survey that has been conducted over the last 2 decades of providers within Canada. So they send the survey out to about 12,000 physicians. Their response rate is roughly 21%. And it's broken up by province to show what the physicians are saying that they are perceiving as the wait times for their patients to be seen based in the number of weeks. And so the darker bar is waiting from the primary care physician to the specialist, anywhere from 6 weeks to 27 weeks. Great variation within there. Some of that is due to the number of physicians that are available. And in some places here in the U.S., it does take longer than 6 weeks to see a specialist. And then the gray shaded bars show the wait from the specialist to the actual treatment time. And then the next slide is by treatments. So you can see that what the report outs were, radiation oncology, medical oncology, so treatments for cancer, very little wait time. Those wait times are probably better than some of the wait times that you see in the U.S. Especially what happens is Medicaid, definitely, your uninsured patients, definitely, they do not have access to specialists. Specialists refuse to see these patients because of the minimal reimbursement that they receive. So I would argue that their wait times are longer than this currently within the U.S., especially in specific regions. And so this just shows the variation that Canada is experiencing. So then the last slide, I can't tell you exactly what the impact would be on Carson Tahoe if we were to move to a single payer system. There are going to be winners and losers within that. Typically what you will see, and this is a study that was done in New York, so the left-hand side shows under current Medicare rates, those hospitals that would gain revenue are in green. Those hospitals that would lose revenue is in red. By losing revenue, it doesn't mean that they are not profitable. It just means that they have less revenue than they currently do. And so, when you think about it, the winners are most likely those that currently have high uninsured and uncompensated care. The losers are more likely those with high private insurance currently. So I shared the numbers earlier with what the breakdown is for Carson Tahoe, and there definitely needs to be changes to the system. What the actual impact will be locally is unknown. And I challenge you with a couple of things at the end. So we've talked a lot about the hospital side of things, and very hospital-centric, and accessing care on the hospital side, and rightfully so, because that's where the highest cost and expenses in the healthcare system. But I also mentioned the reduction that's occurring in the number of hospitals across the U.S. And part of that is due to increases in technology. Changes continue to happen from a technology perspective. More and more services are moving to the outpatient setting. More and more services could potentially be done in the home. Artificial intelligence is on the forefront. Gene therapy is out there. So the question is, the other question out there is, what is the role in the future for hospitals? And how does that play into this payment reform conversation? Because there potentially could be even less and less hospitals, but how do we provide care outside of the hospital setting in a more cost-effective manner for our communities? Thank you.
That was a tremendous amount of information being shared, so thank you very much for that. We have roughly 25 minutes for questions and answers. And you had them well trained. So I'm going to ask, let's see. It seems like since Doctor is a little more familiar with the foreign aspects of things, the question that is here is Japan has thousands of payers, just like the U.S., yet they have far lower premiums and better outcomes. The question is why?
My understanding of the Japanese system, and if you want to know more about a variety of healthcare systems, I've got it on that one handout about the financing, and I'd recommend this book, Healing of America, the global quest for cheaper and better and all that. But anyway, my understanding of Japan is it's negotiated fees. Those are negotiated nationally, and they're less. So Japanese doctors see a tremendous number of patients. It's and health-wise, there are probably some cultural things there. It would be more appropriate to compare Americans to Europeans than to Asians, probably, in general.
Anybody else have anything you want to add? Okay. So the next question, and I'm going to direct this one starting with Mr. Duarte. Does the new proposed system, does it expand mental health care?
I think one of the things that, can you hear me?
Did the system go off?
That's right. I'll just speak up. One of the things that I think has really had the most impact on mental health care in our system, our current system, is the Mental Health and Addictions Parity Act. And so that has required insurance companies across the nation to make sure that, and the Affordable Care Act, which expanded on the Mental Health Parity Act, but that's required insurance companies across the nation to make sure that health insurers provide the same type of coverage as they would for a medical disease, for mental health services. The one caveat to that, there's actually two caveats to that, and I'll get to the answer about the new system. One of the problems with the Mental Health Parity Act is that it doesn't cover self-employed insurers. And so, like, for example, in Nevada, a large number of health insurers were large corporations like casinos. And they fall under a different, or their union plans, like the culinary health plan. And they are protected from any kind of insurance regulation as a result of the Taft-Hartley Act. And so they don't have to provide the same types of services as employer-based coverage or exchange coverage. The second issue has to do with really, I think, the thing that Dr. Lyons has spoken to, and that's really access to providers. And we really have not done enough across the nation to make sure that we've got an adequate network of mental health providers available for patients. So with the new system, one of the things that Medicare falls short on, and it's really, I haven't seen it addressed, so that Dr. Lyons may be able to talk to this in any kind of new proposal, is that Medicare covers very little mental health services and limits those services to very, very specific types of providers. So, for example, people that are not included in the Medicare program are those folks like marriage and family therapists, licensed clinical therapists, and so there's a whole host of mental health professionals that aren't covered. Psychologists, licensed clinical social workers, and psychiatrists are covered providers in Medicare. But right now, the Medicare system is not what I would call a benchmark or the high point of mental health care in the United States. And for seniors, that's a really significant issue. So, hopefully, if legislation passes, there's a serious look at what we need in terms of mental health care, and unfortunately, it's not Medicare.
Thank you. Actually, this question is a good question. I know that there are issues out in rural Nevada related to insurance product. So the question, I'm going to address it to Ms. Korbulic, is, does this model improve the rural health care?
Okay, and I'm tall. Well, okay, so I'll admittedly, I don't know enough about the model to say yes, it absolutely impacts rural coverage. But if you take a look right now at rural coverage with Medicare, we don't have problems with Medicare in rural areas. And so if that's the plan we're leveraging, then I think that there would be an opportunity for any rural Nevadans to access. And we probably wouldn't play the same volatility game that we do right now about who's going to cover rural Nevada.
Thank you. So this next question goes to Ms. Joy. And the question is, do you believe the Medicare for All program submitted by Dr. Lyons is plausible and benefit to society?
Are you a healthcare economist?
No. So there absolutely are advantages to the population in general. Anything that's going to increase coverage for all. We've seen it with Medicaid expansion. We've seen the increased access through that Medicaid expansion, and the same thing is likely to happen with Medicare for all as well.
Can I add to that?
Sure.
This is actually where I get booed off the stage by a lot of folks, particularly younger folks, when I talk about Medicare for all. But if you recall my presentation, it was about incremental health policy change over the decades. And so I think what we have to be, and forgive me for saying this, Dr. Lyons, but I think we have to be pragmatic in terms of how we approach this. I think the end point is where we need to be, which is national health insurance, a single payer system, and that's where we need to get to. We have to find a way to, a glide path toward that type of new program. I think the worst thing that we can do is assume that we can jump immediately to something like that. And one of the things that I applaud Governor Sandoval for was taking the step to expand the Medicaid program when we had a 23% uninsured rate for all Nevadans, and to enact the exchange. We all knew at the time when that was happening that there weren't enough providers willing to take Medicaid patients, but he still took the step to incrementally change health policy to provide coverage. Now what that does is, if people have coverage, eventually, we hope, with other types of policy changes, we will see more providers coming into the state in order to serve this patient population. There's a lot of other factors that are involved, reimbursement rates, all those types of things we could debate. But the first step is to provide coverage. And so I think the step that the Governor Sandoval took, that President Obama took with the passage of the ACA, or the enactment of the Children's Health Insurance Program in 2000, or the enactment of the Medicare program, those are all important steps that we're taking toward the same goal of expanded health coverage for all. But it's not going to happen overnight, and it's not going to be the snap of a finger, because there are too many strong lobbying opponents to this for anything like this to get passed immediately. And we have to face the fact that the insurance companies, they're some of the largest corporations in the United States, big pharma, pharmaceutical manufacturers, and even hospital corporations are going to be fighting this tooth and nail. And in fact, some physician groups are going to be fighting this tooth and nail. And so we're going to have to expect that this is going to happen incrementally over time, and that there will be a glide path toward a future with a single payer system. I'm certain of it. I may not live to see it, but I think that that's where we're headed.
And I respectfully disagree. I think that we made a major leap in the 1960s, mid-1960s, with Medicare and Medicaid, and it was highly opposed. In addition, while the insurance companies and pharmaceutical industry and hospitals do represent a large lobbying force, it's huge in Washington, they are nothing compared to the rest of the economy. And business in America can no longer afford this kind of expense. We're no longer competitive internationally with this kind of expense.
Okay, this is a long one, and I'm being told that a lot of people want to know the answer to this one, so let's see what you have to say. This one says, I went to a talk recently. 3 physicians spoke, one from Canada, one from Mexico, and one from Australia. All have government-run insurance. All 3 countries have private insurance also. They said that allows those who can pay get quicker service. Do you have any comments as to why these governments need private insurance? You're shaking your head. You want to go ahead and respond?
I actually read a whole thing about this right before I got here, and I thought it was really interesting. There was a professor from Johns Hopkins University who wrote a piece about that every universal health care coverage country uses private insurance in some way, shape, or form. And they use it in 3 different ways. Some countries require everyone enrolls in health insurance using private insurance companies. There's private supplements. So Canada and Europe, they use supplemental private insurance companies to do things like prescription drugs or elective surgeries. And then there are other companies that are, or other countries like England that use private insurance to get faster, better care. And in England, what their big policy debate is, should people be using supplemental insurance to fast track through the healthcare system? That's their main policy issue. Ours seems much bigger, more concerning.
When you talk to the healthy economists, they want to limit that ability, because as soon as you start to do that, then you decrease the impetus for everyone to make sure that you have good basic health care. Let's just remember that these other nations do it at half our cost and get better health outcomes. Half the cost and better health outcomes overall. And they don't risk bankruptcy. Okay? Now, if you're in the 250,000 plus bracket, you know, sorry, you might have to wait with the rest of us, the other 95%.
Okay, this question is directed at Ms. Joy. Said you posted a slide on terminology. Could you please clarify the difference between Medicare for all and universal health care?
When I put the slide together, I put it up there just as interchangeable terminology between single payer system, Medicare for all, universal health care. So essentially saying that from a single payer, it encompasses potentially Medicare for all, if that's the program, that the way that we're going to classify it, or universal health care, which again is talking about access for everybody across the board. So they're all interchangeable.
Thank you.
I would clarify that a little bit. Universal health care just means you're going to get it to everyone. Everybody's going to be universally covered. Medicare for all is a way to provide that via Medicare.
Okay. I'm going to ask the question and I'll let you all respond. Currently, I've been told providers have to check with Medicare to see if the procedure is covered. That may take up to 3 days. On a single payer system, will the same services need prior authorization?
The answer is yes, and it's a pretty simple yes, because, and Dr. Lyons pointed out for this, because what you really want to do is you want to make sure that your primary care provider is the one that's providing the majority of your care, and in their opinion, that it's deemed a necessary procedure. Obviously, if it's elective, that's your choice, and some of these systems don't cover it. So I think, the role of the primary care provider becomes even more important in the system, where you really do need to to scrutinize costs and to scrutinize expensive procedures, especially where you can have equally efficacious procedure done at a much, much lower cost, or in a facility that is at much, much lower cost. And so the role of the primary care provider becomes exceedingly important in these systems.
So the VA being a socialized medical system in which I worked for 5 years, it's much easier than the private sector, where you have every single patient is a different thing and a different problem in terms of getting them cared for. In the VA, you know exactly what's covered, how it's covered, and if they need something outside of that, you know how to get it. And take care of it.
So this one is to Mr. Duarte. How much does the Medicaid program cost taxpayers in Nevada?
Oh, jeez.
Do you have that budget figure there, Ms. Korbulic?
I actually wrote something down about
So I think it's in the, let's see.
$500 or $504.
No, they want to know what the budget total was.
Oh, it's
So-
$12 billion.
Well, in over 2 years, it's a total of $12 billion. Now, keep in mind what Mr. Korbulic talked about, and that is that in the Medicaid program, about 70% of the dollars are federal dollars. Up until the time that Governor Sandoval expanded the Medicaid program in 2014, Nevada was getting back, actually was not getting back the federal dollars that you all paid for in federal taxes. Medicaid is the largest federal tax return program to a state, and so the fact that the Medicaid program's been expanded actually means that there's a net positive influx of federal tax dollars from other people's money, other states, not our own. And so that $12 billion becomes a budget figure that's thrown around a lot, but is a little misconstrued. It's probably about $500 million in state general revenue that's used each year, but the majority of the dollars for Medicaid are spent are federal dollars. One thing I wanted to mention, because we were talking about administrative costs and the cost of insurance that insurance companies impose on health systems. Dr. Lyons talked about Medicare, which runs traditional Medicare has an administrative overhead cost of about 2%. And so it's a very effective government-run program. Medicaid programs across the nation, you've seen one. There are 50 different ones, but in Nevada, on average, it's about 5%. So it's a little higher cost, but it's still, from an administrative point of view, pretty cost effective. The problem occurs though when you start giving money to insurance companies to run your programs, whether it's Medicare or Medicaid, and then you're looking at an administrative overhead that Dr. Lyons talked about of between something of the nature of Medicaid, it's about 12% for insurance companies, but in the Medicare program it can go much higher than that. So the insurance companies take up a lot of those dollars, and it's a lot of unnecessary costs.
And you don't get a Band-Aid for it.
Okay, given the validity of the volatility, can't even say that tonight, the volatility of the federal government, would you recommend that our state legislators do more or something different to improve health care for Nevadans? And let's start with Ms. Joy.
So they actually have, from a state legislature perspective, in the last legislative session in 2017, and the folks to my right probably know a little bit more about it than I do, but there are federal dollars that are still available from a Medicaid perspective, and so in the last legislative session, the decision was made, and I don't have the bill number in front of me, to move forward with a provider tax. And the provider tax is on the hospitals, not the physicians. And with that provider tax, each hospital would be taxed, and then the federal government would match that tax dollar, and the money would come back into the state, and that is how the legislature is looking at funding additional Medicaid reimbursement for the hospitals to be able to expand coverage and access.
Yeah, just by way of background, when I was administrator of Medicaid here in Nevada, we enacted a nursing home provider tax, which did the same thing. And the problem with provider taxes is there's winners and losers in the system, and the second problem is it doesn't reduce cost. It just pays people more using their own money as a federal match. So it's an incentive to spend more actually, and not reduce costs. So it has its pros and cons, but it is a way of getting hospitals more Medicaid dollars. Medicaid covers about, it depends on who you talk to and which hospital you're talking about, but about 70% of the cost of a procedure, sometimes lower than that. Medicare about 85%. So it's a way of getting more dollars into hospitals' hands in order to take care of more Medicaid patients.
Doctor, won't there be just as much record keeping with Medicare for all as there is now?
There are a lot of programs out there to try to get us our quality up, pay for performance and HEDIS measures and things like that. None of those have been really proven to actually improve quality, and in fact, sometimes they've been shown to decrease quality because of gaming the system. But a lot of your data entry is spent putting that in there so you can get paid. So I would say that it's going to decrease it. I mean, why would it be different for us when the rest of the world is documenting what needs to be said and we're documenting what needs to be done to get paid?
Okay. Address this one to Heather. Some estimates say that what the average person now pays in a healthcare premium would be about the same as the amount of tax levied for the universal health care. Can you speak to this?
Yes. I mean, okay, what would you like me to say on that? I mean, I guess if the goal is to provide universal coverage and we're going to charge the same amount that we're charging right now, I'm not sure that that is real progress. And so, I mean, it sounds like from the thing that was described by Dr. Lyons that we're looking at lower prices with better outcomes, and I think that should be the goal. Yeah.
You know, and again, I think this is going to be a glide path to a better health system that's going to take some time in order for us to achieve some of the cost savings that we're talking about. But I will tell you that, I run a community health center. We have access to lower prescription drug pricing for our patients as a result of being a federally qualified health center. It's a program called the 340B program, which I won't talk too much about. But you folks have probably seen commercials for a drug. It's a drug for rheumatoid conditions. It starts with an H and it ends with Humira. The retail price of that drug, when you get it through your insurance company, if you have to get it, it's about $5,000 a month per prescription. Because we get access to better drug pricing as a federally qualified health center, I challenge any of you to guess how much I give it to our patients for. $25 a bottle a month. Okay? That's even higher than the VA gets it, because the VA is allowed to negotiate pricing. So there are some things that we can do, and I mean, there's a lot of alternatives. I mean, I'm not trying to discount the program Medicare for All, but I think we're going to have to go on this glide path in order to negotiate better pricing, because otherwise we're going to be affecting the existing infrastructure to try to do it overnight. The infrastructure of things like community hospitals, critical access hospitals in rural communities, even federally qualified health centers like the one I run. We are all part of an existing healthcare system, and we count on the current laws and infrastructure to make sure that we can continue to do our job. And so those changes can't occur overnight. And so I would just say that, again, we're going to have to get on the glide path toward a better future if we're going to see lower costs and universal coverage for everybody.
I say give your $1,000 to the government instead of the insurance company and get, $998 back in health care versus giving it to an insurance company and getting $600.
Poverty, and to give the poor hope, such as preventative care, not avoiding the doctor, meds, or tests because of costs. Can you speak to this?
As somebody that spent almost my entire professional career working with low-income populations and families, I can tell you that health coverage as a benefit is a tremendous benefit to low-income families and individuals. And so, to say that programs like Medicaid really don't have an impact, or that we need universal health coverage and a brand new health system, I think the fact that people have coverage, the policy changes that we've made here in Nevada have had an impact, and I can tell you why. Because we have patients, literally 2,000 of them, who have diabetes and other chronic conditions in our practice. And hundreds of them did not have health insurance coverage prior to the Medicaid expansion. And as a result of that, they were at least able to access prescription medications without having to sacrifice paying the rent or buying food. And so that benefit in and of itself has had a tremendous impact on their lives. And despite the fact that we were able to give them low-cost drugs, they weren't able to get it from everybody. So the fact that you have coverage is an important stepping stone toward an improved healthcare system. And so again, I'd like to say that it really can help people to elevate them out of poverty. It's helping them not having to sacrifice food or rent or car payments or gasoline or daycare for their kids, and enables them to get health care at a cost that they can afford. It's not the panacea. Again, looking to the future, I hope that we see a system like that. But I think the steps that we've taken so far, particularly here in Nevada, are really important ones, and they need to be celebrated and acknowledged.
One last global question. It appears that insurance companies may be the biggest obstacle to an improved system. Is this true, and will they still have a significant role?
Again, Switzerland went to nonprofit insurance companies, so they were nonprofit, and they spent about 25% less. I saw something today that said they spent 47% less, but I don't think that's quite accurate. It's probably more like 25 to 30%. They did that in the mid-90s, so you could just tell your insurance companies, look, you can either exist or not, and you have to go nonprofit. Blue Cross Blue Shield was nonprofit, but it is now mostly for-profit. I think all of them are for-profit because they couldn't compete with the for-profit category. So we could start there if you want to do incremental change. I mean, I'm out for the insurance companies without a doubt. So, you know, whatever you can do to get those guys.
I'd like to make a comment because I'm probably the only one here that actually was the president of a nonprofit HMO and was the founder of a nonprofit HMO in Hawaii. And it was a Medicaid program, HMO, and started it in 1993. A group of us healthcare types running federally qualified health centers got together and started our own insurance company that's still in existence today. It's called Aloha Care, and it is a very cost-effective way of providing health care coverage. In fact, I was told that it was the last nonprofit exempt, it's a 501c4 corporation, the last 501c4 granted to a medical insurance company ever. But it works, and it's a very cost-effective type of system.
Thank you. Thank you for all of your attention tonight. Thank you, panel, for all your presentations and